I think this piece of work and a similar piece of work that we're talking about at this meeting tomorrow is really trying to focus on, can we identify specific biomarkers associated with response and resistance to targeted therapy in renal cancer. And one of the things that we've discovered is not only are individual tumours comprising of multiple different clones that are developing in individual ways, but when you give targeted therapy, they seem to affect each clone slightly differently. What we did in this study is we took biopsies before therapy, multiple biopsies before therapy, and then multiple biopsies after 12 weeks of therapy. And we wanted to try and map the clonal evolution of the cancer with therapy. And what we discovered was that actually the tumours, when you give drugs, become more diverse, become more variable, because this process of clonal evolution appears to accelerate with the association, the addition of new drugs. It's very, very difficult to do, and in fact it's not done particularly well, because what you really would want to do is take a biopsy every three or 4 weeks. But patients, obviously, for compassionate reasons, are not wanting to have lots of biopsies taken. So what we've done is take multiple biopsies on 2 separate occasions. But one of the many flaws of the piece of work is that we only have a time point 0 and a time point at 12 weeks. And if you really wanted to map this clonal evolution, if you really wanted to map the change properly, you probably would want a third sample at 24 weeks too, to see if those changes continue or slow down. I think in a nutshell what this work has shown, and there are a number of people involved and a collaboration of a number of different centres, but in a nutshell what it showed is that the addition of targeted therapy like sunitinib to a cancer like clear cell renal cancer does not show the cancer behaving in one direct way to the drug, but actually it's reacting in multiple different ways, and there are multiple strands and multiple processes going on simultaneously. So one patient, one drug is not having one effect on the cancer. One patient, one drug, multiple effects on the cancer. And in fact, what we're even showing is that each individual metastasis may be behaving in a slightly different way, because the clone, the makeup of the metastasis, will be different from the metastasis next to it. I think what it's showing is that the cancer is changing faster than we are able to keep up with, and that's why resistance is developing. So it's not that it's cleverer, but the infinite numbers of mutations and permutations that can occur over time mean that when we put hurdles in the way, after a period of time, by luck alone, the permutations and combinations of different mutations will allow the cancer to evade what were initially successful blocks, becoming less effective. If there was in each patient only one cancer clone, and that never changed, you'd be able to take a biopsy, look at a marker, target that marker. What we're showing is if you take lots of biopsies, those markers are all different. And if you give therapy, each of those individual markers will react in a different way. So unfortunately, personalised therapy, whilst it sounds very attractive, is probably a lot more complicated in terms of what's going on under the bonnet than at first would be apparent. I think what it suggests to us is that we need to look at crucial changes in particular cancers. So we know, for example, in some tumours, Herceptin, HER2, is a very powerful driver. But these less powerful drivers are probably actually part of a multifactorial process. And it may be actually singly targeting one group of proteins, like, for example, FGF in renal cancer, is not going to be able to solve the whole problem. I think the hope is that we've discovered this is a problem. And it's not just our work, it's lots of other people have by the next generation sequencing, and some of the techniques that we're developing to identify these problems are becoming much more widely available and much more sophisticated. So we're going to get better at monitoring the dynamic changes occurring, and we may even be able to do that in blood. And I think the next positive aspect of it is some of the newer immune type therapies. The process of re-educating the immune system to fight cancer actually is exciting, because that can also adapt with time as the cancer adapts with time. So I think we probably need to think of other ways around this hurdle that we've discovered. But I think in the short term, what we need to do is find out more about this process of molecular heterogeneity and what effect treatment has on it. I think we need to learn more about it. So I think we need to persuade people to do more trials where we take sequential tissue from patients. There have only really been a handful of studies where we've really gone in renal cancer, where we've really gone in and attempted to solve this problem and answer some questions. And so I think we need to collect more tissue. So that's the first thing to do, to get a better understanding of how big the problem is. As I said before, there are lots of shortcomings of our work, not least of which is we've only got 2 time points. And really you'd need at least 3 to really show if these changes are going on. So I think the next thing to do is better define the problem we face. And then only when we realise how big the problem is, can we work out how to address it. I think the first thing to say is that if there are trials available where tissue is optional, I think it's very important that we do collect tissue from patients in real time, because I think historical tissue taken many years ago is not representative of the here and now problem. And then I think the second issue is that in those areas where we haven't yet developed biomarkers, and renal cancer is one of those, we may be beginning to get to the bottom of why it was being more difficult than we originally thought. So actually there are some positive aspects to this. We're beginning to work out why some of the drugs that we know work initially are no longer working so well.